panelists and members for joining us for this important discussion. In March 2020, the United States declared the coronavirus a national emergency. Our country quickly descended into the worst public health crisis in over a century. At that time, we had few tools to protect ourselves and our families from the coronavirus. Our lives changed dramatically overnight. Many people faced devastating choices between staying at home to stay safe or earning a living for their families while putting themselves at considerable risk. 2 years later, we live in a different world. We now have abundant tools to fight the coronavirus. Most importantly, we have safe and effective vaccines, which have already saved countless lives. And for those at greatest risk, we now have treatments that are highly effective at preventing the coronavirus from causing severe illness, hospitalization, and death. Thanks to President Biden's leadership, we are emerging from the crisis phase of the coronavirus pandemic. As a result of the Biden-Harris administration's efforts, the nation has made significant progress in containing the virus. The administration has helped to vaccinate over 2/3 of Americans, overseeing the development of life-saving treatments, and provided critical supplies like N95 masks and rapid tests for Americans for free. These steps have saved lives, reduced the burdens on hospitals around the country, and enabled robust recovery. The numbers of newly reported cases and hospitalizations nationwide are now at the lowest levels in nearly 8 months, reflecting the tremendous progress that has been made. The Centers for Disease Control and Prevention has been able to ease recommended mitigation measures in communities in which 98% of the American public lives. Now that we have the tools to fight the coronavirus, we can transition away from treating the coronavirus as a crisis. Those of us who are fully vaccinated and boosted can now feel safe going about our daily lives without putting our communities at undue risk. Of course, just as public health officials work continuously to protect the American people from a wide array of health threats, our nation's response to the coronavirus must continue in the post-crisis phase. We must take particular care to protect the most vulnerable. We know that the coronavirus can surprise us. Recognizing this, the Biden administration recently released the National COVID-19 Preparedness Plan, which set forth a robust and comprehensive strategy for the next phase of the pandemic response. The plan outlines critical steps to ensure that we can continue to protect against and treat the coronavirus, prepare for new variants, keep our businesses and schools open, and vaccinate the world. For the president's plan to succeed, however, Congress must provide additional funding. Yesterday, administration officials notified Congress of the dangerous consequences that will occur if we fail to act. If Congress fails to provide additional funding, we will be unable to secure sufficient booster doses or variant-specific vaccines if they are needed in the future. Providers will no longer be able to submit claims for testing, treating, and vaccinating the uninsured. We will be forced to end the purchase of critical coronavirus treatments. In addition, we will not be able to invest in a universal coronavirus vaccine that will provide protections from future variants. Our testing capacity will decrease, as will our ability to rapidly identify and assess emergent variants so that we can respond expeditiously. In short, if Congress fails to act, we must increase the risk that our hard-earned progress will be squandered, and the coronavirus will become a national crisis once again. To my colleagues who are concerned about the cost, I would offer the time-honored axiom that I trust the public health experts joining us today are very familiar with: an ounce of prevention is worth a pound of cure. I look forward to hearing from these experts about how we can move forward and stay beyond the coronavirus crisis, and how the Biden administration's plan will help us achieve those goals if we provide the resources. With that, I would like to recognize Ranking Member Scalise for his remarks.
Thank you, Mr. Chairman, and I'm looking forward to this discussion on the topic of actually moving beyond the COVID-19 pandemic. I think a lot of people in America are there. Most Americans have been ready to move on from never-ending COVID restrictions and mandates for a long time. But many far-left politicians have been dragging their feet because they were clinging to this new emergency power that many people had and using COVID as an excuse for government overreach. So many Americans have lost their livelihoods. Young people who have lost opportunities, children, as we've had many hearings on, who have been devastated by the loss of learning that was held from having schools shut down. All of these shutdowns, and in many cases by hypocritical leaders who themselves were not participating in the shutdowns that they were forcing on other people. Union bosses, as we saw, who interjected their viewpoints into the science, getting the White House to change guidance to bow to union bosses at the expense of our young children, millions and millions of our young kids who were denied opportunities to learn. So many people who took advantage of those emergency powers to exert control over people's lives. Now, we need to have an open-minded discussion about how to turn the page. We need to learn to live with the virus by following the medical science, not the political science that we've seen in so many instances. We have to hear from public health experts. So I want to thank our panelists who are going to be a part of this discussion. But we also need to hear from parents, those parents whose kids have experienced learning loss or developmental delays because of school closures and mask mandates for the last 2 years. We need to talk to workers, to those small business owners who lost their livelihoods as communities were forced to shut down. As we finally start to move on, it is absolutely critical that we learn from the many, many mistakes that have been made. Personal freedoms have been trampled on through vaccine mandates and censoring of free speech. Our public health institutions, like the Centers for Disease Control and Prevention, have lost public confidence. The politicization of the pandemic has been costly and damaging. Mr. Chairman, I hope we'll have hearings on some of these other topics as well in the coming weeks and months. I think it is the responsibility of this subcommittee to learn from the mistakes of the past so we don't repeat those mistakes again in the future. And again, Mr. Chairman, look forward to hearing from our panelists. With that, I yield back.
Thank you very much, Ranking Member Scalise. Now, I would like to welcome today's participants. Dr. Jewel Mullen is the Associate Dean for Health Equity at Dell Medical School at the University of Texas at Austin, as well as an Associate Professor in the school's Population Health and internal medicine departments. Dr. Mullen is an internist, epidemiologist, and public health physician leader, whose career has spanned clinical, research, teaching, and administrative roles, focused on improving the health of all people, especially those who are underserved. Dr. Carlos Del Rio is the Executive Associate Dean at the Emory School of Medicine and Grady Health System and a Distinguished Professor of Medicine in the Division of Infectious Diseases. Dr. Del Rio's research focuses on the early diagnosis, access to care, engagement in care, compliance with antiretrovirals, and the prevention of the HIV/AIDS infections. Dr. Robert Wachter is professor and chair of the Department of Medicine at the University of California in San Francisco. He is the chair of the International Advisory Board of the Healthcare Improvement Studies Institute at the University of Cambridge, a master of the American College of Physicians, and an elected member of the National Academy of Medicine. Dr. Lena Wynn is a practicing emergency physician, professor of health policy and management at George Washington University, and a non-resident senior fellow at the Brookings Institution. She previously served as the health commissioner for the city of Baltimore, the president of Planned Parenthood, a global health fellow at the World Health Organization, and a distinguished fellow at the Fitzhugh Mullen Institute for Health Workforce Equity. Thanks to all of you for joining us. I will now begin the question and answer session with my own question. Over the past year, President Biden and Democrats in Congress have made significant progress in providing the nation with the tools needed to end the coronavirus crisis and transition to a non-emergency approach to the pandemic. The results speak for themselves. As a result, the Biden administration's unprecedented vaccination campaign, purchase of millions of doses of life-saving treatments, and distribution of hundreds of millions of free tests and N95 masks, coronavirus hospitalizations, and mortality rates in the United States have plummeted to the lowest levels since the Delta variant emerged last year. Dr. Wynn, you wrote recently, and I quote, "Pre-pandemic normalcy is possible now that we have the right tools," end of quote. I'll start with you, and then I want to hear from all the participants. What is your assessment of the progress we have made in fighting the pandemic, and what does it mean for the day-to-day lives of the American people?
Chairman Clyburn, thank you for the question and for your leadership. In many ways, I am much more optimistic now than I've ever been at any point in the pandemic. And that's for the reasons that you articulated, that we have far more tools than before. And science has really delivered. We know, for example, that individuals who are vaccinated and boosted are generally very well protected from severe illness. And now we also have treatments, we have testing, we have other tools that help us to be able to live with COVID. And so for the majority of Americans, it is possible to return back to pre-pandemic normal, not because the pandemic is over, But while we have this relative lull with a reduced number of cases, I believe it's important for us to urge people to resume their lives, including, in many cases, to go maskless in schools to make sure that we don't have any more shutdowns, as the ranking member mentioned, that have so adversely impacted our country. At the same time, we cannot let our guard down in the sense that there is the threat of new variants that might emerge. We're already seeing upticks in cases in some European countries. We're seeing China re-implement shutdowns. We have to consider that surges could once again occur in the US. But to me, that's even more reason to urge individuals to try to resume pre-pandemic normal, while also urging the government to do a lot more. If it's anything that we have learned thus far, it's that preparedness and prevention are absolutely critical. We cannot wait until there is a crisis before we act. And so now is the time to fund treatments, additional booster shots, make sure that we have sustained testing infrastructure, and also remembering that while most Americans can move on with their lives, there are still 7 million people who are moderately or severely immunocompromised. There are still many millions more who are elderly with chronic medical conditions who still have fear of COVID and the severe illness that comes with it, and we have to be attentive to protecting them as well.
Well, thank you, Dr. Nguyen. Dr. Mullen?
Thank you, Chairman Clyburn. I want to agree with Dr. Nguyen in adding my optimism and tell you why I nuance that. Because I'm optimistic that we have seen the fantastic results of the public health response in the face of this crisis. But having worked in state and federal public health through more than a decade's worth of public health emergencies, the extra optimism comes from perhaps knowing that the public has a better understanding now of what they can do in a public health preparedness framework that isn't one that we actually wait for to implement during the crisis. So the notion of prevention and having people understand that prevention is also about continuing to build up public health at the local level, at the state level, and at the federal level. So we're not playing catch up to try to get ahead of a crisis is actually very important as well. And I think our response, our national response to COVID, as difficult as it has been to get people to coalesce, has also been a learning for all of us. And I get to say that as well, thinking that through my years in state public health, when people talked about, is it public health or the economy? COVID has actually taught us that when we respond, we're responding to two sides of the same coin. They're both on the same side. It's not either or, it's not binary. And the measures that we've put into place can be rolled out in ways that continue to support economic recovery and people's recovery at the same time that we improve the public health.
Well, thank you, Dr. Mullen. Dr. Del Rio?
Thank you very much, Chairman. I'm not going to repeat a lot of the things that were said already because I agree with them, but I do think that there are a couple of things that I want to emphasize to your committee. Number one is that investments in public health infrastructure can make a huge difference during a crisis. We were way behind in the US. We didn't have the infrastructure to do genomic sequencing. Our public health had been decimated. We didn't have enough people in public health. And I think we did not have a good response at the beginning of the pandemic, and we continued to try to respond appropriately because we did not have the infrastructure necessary. Number two is that people make a difference. People matter. And I would want to talk about healthcare workers. Healthcare workers are tired. Nurses are leaving in big quantities. And I would tell you that we are going to pay for that long term if we don't think about a solution going forward, because we're not going back to healthcare the way we knew it before the pandemic. Healthcare is going to need to be transformed. And this is an opportunity to transform healthcare in America. But if we think we're going to go back to where we were, my answer is simply it's not going to happen. And the nursing crisis and the physician crisis we're going to see in our country are going to be significant, are going to go beyond COVID. Number three, I really think that, the pandemic, if it taught us one thing, is that health disparities are really important. And the disproportionate impact of this pandemic on Black and brown individuals, on the poor, has been quite significant. And health disparities are not new in this country, and we can no longer accept health disparities, and we need to do something about them. We talk about them, but we're not doing enough to end them. And finally, I would say that science made a huge difference. And I think we need to, again, the years of the investment in science that Congress has done through the National Institutes of Health has paid big time. I'm an HIV specialist. The research in developing an HIV vaccine at the NIH Vaccine Research Center was critically important in developing COVID vaccines. And I can go on and give you examples of how investing in research has made a big difference. And if we are in a different place right now, it's because we made those investments in research. Finally, I want to totally agree with Ranking Member Scalise in that we responded in a very partisanship to this pandemic, and that was incredibly disruptive and inappropriate, and I think led us to a bad place. And I think what we need to do something is we need to come together as Americans. I don't care if you're Republican, Democrat, liberal, we need to have a good discussion like we're having right now. But at the end of the day, we need to do what's right thing, and we need to let science guide what we're doing, because that is really what's going to be the biggest strength America has is its science. The biggest strength America has is that when it comes together, we respond like no other country in the world. Thank you very much.
Well, thank you very much, Dr. Rio. Dr. Wachter?
Thank you, Mr. Chairman. Thank you to the whole committee, and thank you for the honor of being part of this discussion. I agree with most of what I heard. I guess I would temper my optimism with something Dr. Nguyen mentioned, which is that there is some evidence that we may be plateauing out in terms of the recovery from the Omicron surge, and we may be in store for something of a new surge. Whether it reaches the heights of prior surges is hard to know. But the combination of waning immunity, both from natural infection as well as from our vaccines and boosters, the new subvariant from Omicron, the BA.2, and frankly, the end of cautious behavior is going to lead to some increase in cases. That'll be a trade-off. And for example, I think it's perfectly reasonable for people to not wear masks in certainly certain indoor places. But I think we have to be thoughtful and careful. A lot of us are fatigued. It's quite understandable. We want to be over it. We want to go back to 2019. But the virus, to some extent, will dictate that. And it does seem to me to be a time where we want to really focus on what are the investments that we need to make to ensure that we keep this virus at bay, that we allow people to act as normally as we possibly can, that we mitigate the potential impact of some sort of future surge, because none of us want to go back to masking everywhere, restricting travel, restricting workplaces. I think everybody agrees on that goal. The question is, what can we do that allows people to live a life as normal as possible with as few restrictions and allows our economy to be as open as possible? Clearly, to do that, we need to encourage more vaccination, more boosting, potentially another booster, maybe in our future. We need to allow for more testing, and we need to have treatments out there. So, for example, the widespread availability of Paxlovid, the Pfizer oral antiviral, would to a large extent be a game changer. I still wear a mask in crowded indoor places, and in part because I still don't want to get COVID, and in part that is because even though I'm confident that I'm not going to get super sick and die because I've had 3 shots, I still worry a little bit about long COVID. Some studies recently have demonstrated some new concerns about what the long-term impact of COVID is. If you told me that if I got a sore throat today, I could get tested. If I'm positive, I could get to the pharmacy and get a treatment that lowers my chance of getting very sick by 90% and lowers the amount of virus in my system, which probably will turn out to make me less infectious and probably will also turn out to make it less likely I'll have long-term lingering effects of COVID, then I'm going to be much more permissive in my behavior than I would be otherwise. But right now, if I got COVID, I'm not at all confident that I could get that medicine. So that's just an example of we all want to go back to normal. We all want to put this behind us. We all want to move out of an emergency mode. But that is not the time to withhold investment in this. It's the time to redouble our investments in the kind of things that science and frankly, all of you have brought us by the investment in science. We have to make those available in order to support the idea that we're going back to a much more normal place in our lives.
Well, thank you, Dr. Wachter. I now recognize Ranking Member Scalise for his question.
Thank you, Mr. Chairman. Dr. Wen, I'll start with you. You've recently tweeted about, quote, the growing third camp who want to go from polarizing rhetoric to reasonable compromises that allow us to live with COVID-19. You've also recently talked about unmasking your 4-year-old, writing, quote, common sense tells us that young kids need to see phonation for speech development. And you even went on to talk about some of your personal experiences growing up with speech impediments. We know that our nation's children bore the brunt of the pandemic restrictions. In addition to the dire youth mental health crises, state test scores have dropped significantly in both reading and math. And lots of young kids are having a hard time with speech. I'm worried that instead of learning from our mistakes, too many leaders are still eager to repeat these mistakes if there is another spike in COVID cases. And indeed, you can see some still clinging to mask mandates in certain circumstances, such as on airplanes, for example, even though airplanes have some of the best air filtration systems around. So Dr. Wren, I'll start with you and we can go down through all of the panelists. Do you agree that children are in crisis? And given what we know about COVID's relatively limited impact on kids, does the reduced risk of transmission outweigh the downsides that we've seen that come with pandemic restrictions like school closures and mask mandates? And then also, do you think it makes sense to continue mask mandates for airlines while there are no longer those same requirements for large indoor events like concerts or sporting events, as we're seeing many places drop some, but not all of those restrictions? And I would start with you.
Ranking Member Scalise, I appreciate the nuanced and thoughtful way you framed the questions, in particular about schools. I want to say two things here. One is that things have changed. Where we are now in the pandemic is very different from where things were back in December. At that time, for example, we were having a surge of Omicron. Here in Maryland, for example, we were having 15,000 cases in a 7-day period out of 100,000 residents. That number is now about 2,000 per 100,000, which means that the risk is 7 times lower than it was back in December. In addition, we now, compared to last year, we now have vaccines available for children 5 and older, which means that parents who want to are able to vaccinate their children and protect their kids, a tool that was not available a year ago. And so a lot has changed. And I think the key is that we have to weigh risks and benefits. Masking is an important mitigation measure that, like other mitigation measures, like anything in medicine, has risks and benefits. And in this regard, two things can be true at once. There is a real benefit to masking when it comes to reducing transmission of the virus and reducing outbreaks in schools. I think there have been quite a few studies that have demonstrated this. At the same time, I also think it's intellectually honest for us to acknowledge that prolonged masking, in particular in the youngest learners, in children with disabilities, in English as a second language learners, but also in other children, can have downsides as well. And this is the reason why an assessment of risks and benefits as we go through the process of the pandemic is important. When the risk drops because the cases drop and when other protective measures like vaccines become available, I think it's important for us to weigh the risks and benefits of these mitigation measures. And this is why I'm very glad that masks have become optional essentially in all parts of the country. And the vast majority of school districts are allowing parents to have the option to mask their children or not. I think it's slightly different when it comes to plane travel. And the reason I feel this way is plane travel for a lot of people may not be an option. There may be immunocompromised individuals or others who are particularly vulnerable who have to be on planes. And while I certainly agree that an N95, K95, a high quality mask is very protective, I also think it's prudent while you have people coming from many parts of the country to either have masking or proof of vaccination or testing. I would be very happy to board a plane if everybody had a rapid test prior to boarding too. I think that could replace masking. But that's my view on this. I'd be curious to hear how others feel.
All right, Dr. Mullen.
Thank you for your question. Thinking about risk and benefit, part of the answer to that relates to an individual's risk as opposed to the risk for a big population. And that's where we also hear people weighing what they might want to make as a personal choice as opposed to the guidance that we still continue to offer the public. And I'm encouraged, even though it might sound like hedging, that we're getting there to a place where, especially if we don't have another resurgence, things will be even looser than they are right now. But even in that context, what encourages me about what the public has learned about public health is that some people will still decide to be more protective of themselves and their families, even when it seems like the risk to the population has gone down. And that's okay, because that gets to their individual choice. The other thing that I want to add as we think about children and learning and this entire conversation about COVID preparedness is that the recommendations for the ongoing response to COVID are core to our well-being and health as a society in general, beyond COVID. When I arrived at HHS at the beginning of 2016 as principal deputy, we were contending with the Flint water crisis and Zika simultaneously. It's very unusual to have one thing going on at one time. And so the breadth of public health expertise and response is also very important. So even as I think about the components of the plan, as they get to averting economic shutdowns and getting children back to school, ongoing mitigation measures, all of that rolls up into what we need for everyone to be healthier and back to a normal state, when getting back to normal for some people is still going to mean that they're not as well off as others. And so across all of this, the conversation for me also is always about what else do we need to do for the immunocompromised, for the people in rural areas, for older adults and others. And once again, then there's not one simple answer.
Dr. Del Rio.
Thank you, sir, for your question. It's a really important question. And I would say that, yes, I think we have learned in this pandemic how important schools are and how critical schools are for a functioning society. And while I do understand that at the beginning, school closures were necessary, I think they probably went on for way too long. We are, as you say, a generation of kids is at risk in many ways, including mental health.
I think, Dr. Del Rio, your connection is going bad.
I think it's frozen.
Maybe we can go to Dr. Wachter and then come back if Dr. Del Rio's connection gets better.
Sure. Thanks so much. Yeah, I agree. I particularly like Dr. Wen's response, because I do think these are complex questions. They involve trade-offs between risks and benefits. There is no bright line between safe and unsafe. It is all a matter of degree. I think that there is a lesson learned about the schools, that we went on with restrictions longer than we should have, and that there's more downside to the restrictions, particularly in small kids, than I think we appreciated. So I think that's a lesson learned that we should take advantage of as we go forward, both with COVID and potentially other comparable pandemics. I agree that at this point, in communities where the rate of COVID is quite low and the amount of community transmission is quite low, that a mask mandate is no longer appropriate in the schools. I think it's going to be very important to try to create an environment in the schools where kids who choose, or parents who choose to have their kids continue to wear a mask, feel good about that, or not bullied for having made that choice. I think it's a perfectly legitimate choice. I don't have little kids. If I did, I'm not sure what I'd do. I think it's a tough call. And the reason is that we all talk about the very low rate with which kids get very sick, go to the hospital, and die, and that's absolutely true. It's not zero. And this risk of long COVID is, I think, a big uncertainty. We don't know the answer to what happens to you after you've had a case of COVID a year or 2 or 5 years later. I suspect it's going to be okay, but there are a couple of concerning studies that have come out recently. But I think when you weigh all of that together, the downsides to kids, the low community rates in most communities in the United States, and the fact that we can enable parents to make this choice, whether they choose to wear a mask, I think it's perfectly appropriate to remove the mandates. And I do think it really important lesson learned for all of us. I continue to think of the airplanes differently, and the reason I do is mostly that when we make a decision about what to do about the schools, for example, or about a sports stadium, we're taking advantage of what we know about local transmission. How much COVID is there in the community? Well, I'm in Ann Arbor, Michigan today. I'm flying back to San Francisco tonight. I have no idea what the communities are of all 200 people on the plane with me. Nor what they are in the person sitting next to me, whether that person's been vaccinated, where that person's from, how much virus there is in that community. The planes are relatively safe. There's good airflow, and yet for 6 hours sitting next to someone on a plane, I think does carry some significant risk. I continue to believe that wearing a mask is not the worst thing in the world. And so for the planes, and I think if we knew for sure that cases were going to stay as low as they are now and maybe go down further, it might be a different decision, because at some point it's perfectly reasonable to remove the mandate and make that elective, just as we've done in other settings. But I think there's every bit of evidence that the cases are potentially hitting a bottom now and might be on their way back up. And as I think everybody recognizes, if we pull off the mandate now, it's going to be incredibly hard to put it back in. So I think it's a prudent decision to keep the mandate on, at least for the next few months, until we see which direction this thing goes in.
Thank you. Now, Dr. Del Rio is back.
Yeah, can you hear me?
Yeah.
Yeah.
So thank you very much, and I apologize for what happened to the internet. I agree with my colleagues, and I think one thing that, again, we've learned in this pandemic how critically important keeping our schools open is, and we need to do everything possible to keep our schools open. It's particularly important for children of low socioeconomic status, which may not have access to internet, may not have access to online learning. And I think we are putting a lot of kids in risk, but we're particularly put at risk kids of low socioeconomic status. Having our schools remain open, I think, needs to be one of the critical things we do going forward. And for that, I think, having as many, the best way to protect our children is have the adults around them vaccinated. So having the adults around them vaccinated is a critical component. As far as the masking in schools, my only argument about the masking in schools that I would say is that the masking, I'm sorry, not schools, and in airplanes. I would say that having flown, and I fly quite a bit, is that nowadays, even though there is a mandate, many people on the planes are not wearing a mask because they're drinking, because they're eating, and because they're, if you don't want to wear a mask, just buy enough, snacks and eat during your entire flight, and you're not going to wear a mask. And I think we're putting our flight attendants at significant stress by having them try to enforce a regulation that simply is not being respected. I also have concerns that somebody may be flying from city A to city B. In city A, there's no masking requirement. In city B, there's no masking requirement. Yes, when they get on the plane, there's got to be a masking requirement. So I think my feeling is we should go to a mask optional situation. If you want to wear a mask, and that's totally fine. If you need to wear a mask, I think mask optional is where we need to be in many places. I don't think just because there's not a mask mandate, that doesn't prevent me from wearing a mask. If I want to wear a mask, but I should be wearing a good mask if I'm doing that. And as I'm with Dr. Walker, I have no problem wearing a mask if I'm in a long flight, 3-4 hour flight and sitting with a bunch of people. Nowadays, not only because of COVID, but because of many things, I want to wear a mask. I'm worried about influenza. I'm worried about many other diseases. I used to get sick all the time with respiratory illnesses because of the amount of travel I do. I haven't gotten sick in a while. So I think the mask is making a difference in my travel, and I'm going to continue doing it. Whether that means a mandate is required, I'm not sure a mask mandate is making any difference, quite frankly.
Thank you, Mr. Chairman. Thank all the witnesses. Appreciate it.
Thank you, Mrs. Scalise. I now recognize Ms. Waters.
Thank you very much, Mr. Chairman. And I'd like to thank all of our panelists for being here today and participating in these discussions that will help to move us forward. in the way that we've been successful in where we have come with COVID-19. So since the earliest days of the pandemic, we've seen that the coronavirus has had a disproportionate impact on communities of color. The Biden administration put equity at the center of its public health response, including standing up a COVID-19 health equity task force to address coronavirus-related health inequities among communities of color and other underrepresented populations. As a result of their actions, Hispanic, Black, and Asian adults are now vaccinated at the same rates as white adults, which has undoubtedly saved many lives. So, Dr. Mullen, in what ways has the Biden administration worked to ensure the health and safety of communities of color and other underrepresented populations throughout the pandemic? And what more can Congress do to better support these communities?
Thank you for your question. I'll go back to the third week of January last year, from the very announcement of equity, health and racial equity being central to the agenda of the administration. And as someone who has devoted a lot of her medical and public health career to the well-being of all people, I appreciate sending a message from the beginning that leadership was really going to focus on the well-being of all people. That being said, it's been especially important to have a health equity task force that reinforces the notion that equity and assuring well-being and health isn't an add-on, but needs to inform the approach to every component of preparedness and response, public health and healthcare. And I see the work that the task force has done, the report that was released, and the approaches that are even embedded in the preparedness plan that's we've been discussing, to really focus on the most vulnerable, and to do so in ways that I think more people are thinking about the CDC, thinking about socially vulnerable communities, a social vulnerability index, which accounts for racial and ethnic minoritized populations at the same time that it gets us to really think about the layering on of economic and educational inequality. And I was going to add to the last question about education in schools. Let's not take any of these questions in isolation because they are all related. And the approach and the health equity approach to COVID is a reminder that it's not just about race and ethnicity, it's about the impacts of ongoing inability to control one's health, diabetes, high blood pressure, et cetera, and all of those conditions. Just having the conversation and not getting stuck in debates about race has been really important too, because there are people who suffer inequities in every corner of our country. The extra focus on getting testing to rural areas, the notion that we stop thinking about hard to reach communities and own the fact that our services are hard for people to access is another new approach. Instead of thinking we built it and so people need to come to us. And so mobile resources, people who supporting even through the rescue plan, housing people. If you look at the association between vulnerability for health, mental health is really important. So we layer it on. And I just want to add that the ongoing combination of health and social services for families is really key. Economics, jobs, caregiving, childcare are all supports that have to get woven in to get people back to work, children back to school. Kids can't go to school if somebody or parents can't go to work if somebody has to take care of them. And then I'm going to end with this, because you have public health experts. We like to talk data and statistics. The ongoing focus that we're not going to operate blindly or act surprised when we see data that we can already predict because we haven't attended to health disparities is something that I believe the work of the task force and the administration is really pushing us away from.
Thank you. And Dr. Mullen, let me ask you, is there such a thing as vaccination hesitancy in certain communities?
If we want to use that term, but I can't take up this whole 2 hours. There's much more to it than just saying vaccine hesitancy, when a lot of what we have also learned is that people didn't have information or the ability of where they needed to get. And so taking work and putting it in communities close to the people who need information to make the best decisions for themselves has been key. And we haven't always done that with our federal and state resources, to put the resources in the communities closest to the people. So I didn't give you a direct yes or no answer.
You did not.
And part of the reason for that is because I've spent a lot of the past year saying things such as, if you see a Black person, don't see vaccine hesitancy stamped on their forehead. It's much more complex than that.
It is very complex. And when I've worked in the communities where we need to get more people vaccinated, I saw a lot of people who were not ready and who were hesitant to do it. So my experience tells me there was a lot of people who were hesitant to do it. Thank you very much.
Thank you, Ms. Waters. Mr. Jordan? Dr. Green?
Thank you, Mr.
Dr.
Chairman.
Green with
Sorry.
us?
Can you hear me now?
Yes, sir.
Yeah, I just, since we're only getting one question, and I thank you for putting this together, Mr. Chairman, of course, ranking member, for you and your comments. I'll make my question very brief. Dr. Nguyen, you said, I think it was on February the 7th, that the science had changed and the decision to wear a mask should now be an individual one. I was just wondering if there was a study that had been published that somehow changed the science, and if there was, could you explain that from last month or the past couple of months?
Thank you very much, Representative Green. It's the combination of several things. It's the science has changed and the circumstances have changed. And specifically, I was describing the difference between beginning of February and where we were at the beginning of December. At the beginning of December, at that time, I very much supported mask mandates. And that's because we just found out about Omicron. It looked like Omicron was coming like a flash flood or a blizzard, and it was going to overwhelm our healthcare system, as it did in many parts of the country, as it was doing at that time in South Africa. In addition, we didn't know back in December that the vaccines that we have will continue to protect us very well, especially against severe illness, when we have a vaccine and a booster. In February, we knew that. And at that point, we'd also seen that the very quick rise in cases was followed by a very quick decline in cases as well. The vaccines provide exceptional protection. In addition, we also had ongoing information about the benefit of one-way masking, meaning that even if others around us are not wearing masks, a KN95, N95, or KF94 mask protects the wearer very well. And that's the reason why I supported in February removing those same mask mandates that I supported in December, which was always the goal. I think it's important that we say these measures that we put into place really have a time limitation, that they are there for emergencies, but we should be ready to lift them as soon as we are ready when the science and circumstances change.
So did I understand you correctly? You said there was a new study that showed the single mask of just the individual who we're concerned about was enough to protect that individual. Is that what you're saying? Did I understand there was a new study published that gave you that information?
No, rather that it's a combination of the Omicron surge, our understanding of the vaccines still protecting against Omicron, and the ongoing information that we have about the protective effect of one-way masking. So it's the combination of those things that changed between December and February.
So the circumstances changed, the science didn't change.
Well, the science has evolved too, because back in December, we didn't know that the vaccines and boosters would be so protective against severe illness for Omicron. And with that new knowledge, we should then be able to adapt our recommendations. I mean, you're a physician like me, and so I think we always say when science changes for our patients, for example, if there's a new cancer treatment that comes out for our patients, our advice for our patients should change. And that's the same thing that's occurred in this case.
Yeah, I hear people keep saying that, but I haven't heard of a study that's been published. And I get the fact that the circumstances of Omicron and its really absence of bad outcomes and things like that, and the effectiveness of the vaccine. Okay, well, I could be just arguing over semantics, but to me, there's no new study on masks that I've been able to find that show that it changes the protective or non-protective status of the patient. I just wanted to clarify that. Okay, thank you very much. Thank you, Mr. Chairman.
Thank you, Dr. Green. The chair now recognizes Mr. Foster.
Thank you, Mr. Chairman, and to our witnesses. You know, over the last couple of years, we've just seen tremendous breakthroughs from medical research. It's led to multiple coronavirus, therapeutics and treatments and so on, and really transforming the way that we approach the virus today. I worked with several other members of this committee to try to encourage the Biden administration to speed up the evaluation of drug cocktails instead of just a single therapeutic, using existing approved medications. Because, one of the lessons of HIV was that drug cocktails have historically proven the most effective against viruses and their mutations. But one of the frustrations I've had on this and related things is that we don't seem to have a systematic, rapid method of evaluating various proposed, therapeutics and prophylactics during this pandemic. We've seen all of these, you can call them folk remedies or things that are inspired guesses, hydroxychloroquine, ivermectin, vitamin D. I think the juries may still be out on that one. Fluvoxamine, also, I think the jury's out on that, as well as the advanced antivirals, some successful, some not. But it seems like they all should have been evaluated rapidly and on a common platform. And we didn't seem to have that mechanism at the start of the pandemic. And we certainly don't seem to have one now. And I wonder what your thoughts are going forward as to what we should be doing, if anything, in that area. Yeah, Dr. Wachter, you want to have a swing at that?
Sure. Thank you, Representative Foster. Yeah, I think it's a really good point. I have to say that I am impressed with the speed with which we sorted out remarkably effective vaccines, and the speed with which we sorted out the medications and figured out which ones work and which ones don't. And I'm somewhat depressed by the challenges that we've had in communicating on both vaccines and on therapeutics. But I think the point you're raising is absolutely legitimate, that in the same way that a pandemic hits and one should be able to push a button on the pandemic plan that says we need testing, and what are we going to do to get testing as quickly as possible? We need PPE, and we need research on both vaccines and therapeutics. Some of that happened in terms of the funding that all of you provided and came through the NIH and other organizations, and some of that didn't, or some of that happened in a more haphazard and sluggish way than should have occurred. I have to say that the clinical research and the infrastructure to support clinical research is underdeveloped in the United States. And we know that because we have often found ourselves looking to Israel or looking to the UK to figure out which therapeutics work. And obviously their science is no more advanced than ours is, but they had developed and invested in an infrastructure that allowed them to rapidly test things, assess whether they worked, and put out the results of those tests. So I do think a broad look at our overall infrastructure for both vaccine and therapeutic testing is a wise thing to do and an important lesson coming out of it. But it's also really important to tip our hats to the fact that we have come out with these remarkable vaccines. And when you look at a medicine like Paxlovid, it's pretty amazing how, and as you say, it's a single medicine. It may be that a cocktail will work even better, but just as a single medicine, if it lowers the probability of hospitalizations and deaths by 90% and does so safely, that's a triumph. That's really very impressive. So we should celebrate some of the advances we made as well.
Any of the other witnesses have thoughts?
Yeah, Representative Foster, if I could make a few comments on that. First of all, I agree. I think, we have a clinical trial infrastructure in our country, but our clinical trial infrastructure is divided by diseases. So there's an oncology clinical trials group and an HIV clinical trials group and many of us working in an HIV clinical trials rapidly shifted to COVID. My own group did many studies looking at COVID drugs and COVID therapeutics that led to the vaccines, led to many other drugs that have been approved and looked at. But it's also a bit hard to do some of the studies, as you mentioned. And I think we really need to look at how trials are done. And I think in the UK, for example, the recovery study, the recovery cohort has been incredibly informative in evaluating diseases and evaluating treatments during COVID. So I do think that we need to look at how do we do something similar in our country, because we clearly did not do what needed to be done to evaluate the kinds of treatments that you're talking about in a very rapid and expedited way. As far as combination therapy, I couldn't agree with you more. Again, as an HIV scientist, I can tell you, when we started doing combination therapy, it was transformative. But one of the big challenges to many of the combination therapy studies, as you probably know, is that if you have Paxlovid, which is a drug by Pfizer, and Molnupiravir, which is a drug by Merck, getting the two companies to come together and work together is incredibly hard. And in the world of HIV, it was actually through the NIH HIV Clinical Trials Network that became sort of the brokerage, right? That's how we were able to get the Gileads and the Mercks to work together, and therefore we were able to study different drugs. But the problem is that if you don't have that ability to do that, you will never get companies to collaborate. You will never get companies to come together. And again, this is part of what we need to look at clinical trials. As the government is investing, we need to bring industry and make them real partners and be willing to work together in order to develop this combination therapies that you're talking about.
And I have to say that during times of a pandemic that's killing thousands of Americans and many more around the world, we don't want to have long negotiations on this. We want the government to come in and crack their heads together and say, we want you to set up a joint combination therapy trial and have an existing, a trial. Another, you mentioned, there's another one, the Together trial that I think is run out of McMaster. That is just, it's a never-ending placebo trial, and new things just keep rotated in for the treatment arm. And that's a very rapid way to start up one of these trials, instead of saying, okay, now we're going to go and apply for approval to some big complicated, combination therapy trial, which we ought to just have a system where you can plug in rapidly with a new proposed treatment.
I agree 100%.
Okay, well, thank you all.
Okay, thank you. The chair recognizes Dr. Miller Meeks.
Thank you so much, Chairman Clyburn, and I want to thank all of our panelists for joining us today. And if I can, I want to say hello and thank you to Dr. Mullen. As a former director of the Iowa Department of Public Health, I know firsthand the importance of planning ahead. But as a surgeon and an Army veteran, we must also be adept at evaluating situations as they evolve. And quite honestly, throughout the pandemic, this session right here is the most I have heard about risk and benefit and being able to have an interchange without shaming, canceling, or demeaning individuals. My Republican colleagues and I have been advocating for months about the importance of returning to normal. And was said earlier about the number of cases with Omicron, remember that our actions were predicated that we would not overwhelm hospitals and ICUs, not on the number of cases. It's the number of hospitalizations and ICU beds that are available and not unavailable because of staffing shortages. Unfortunately, the Democrats on this committee have only just begun to change their tune, coincidentally in lockstep with recent polling. The pandemic was never about life versus the economy. It was about life versus life. And the overbearing restrictions have led to excess non-COVID deaths in all age groups, but especially in children and young adults due to suicide and drug overdoses. And they have done irreparable harm to our economy, America's children, and our way of life. We must find a way to move beyond the pandemic in accordance with metrics, live with the virus, and return to normal. We are still, as you know, wearing masks on planes, not given the option on the basis of our risk factors, our vaccination, our transmission. We're mandated to wear masks, even though the filtration system is good. And in schools, with extraordinary low transmission among children and low illness, there are still schools where they're mandating masks. In my home state of Iowa, Governor Reynolds has allowed the public health emergency to end on February 15th. The current National Public Health Emergency Declaration is set to expire on April 16th, and it has not been communicated to Congress whether or not HHS plans to extend this deadline. Back in November, other Republican members of this committee and I wrote a letter to President Biden asking at what point his administration plans to lift the public health emergency. The letter requested that he publicly announce a roadmap for lifting the emergency declaration, including specific metrics that would constitute grounds for ending the PHE. Yet we still have seen no plan or benchmarks announced. And the president's plan released after the State of the Union does not indicate benchmarks employed to determine if or when the White House or the CDC will re-employ mask mandates, lockdowns, or school closures. In other words, there has been no signal truly to end the public health emergency authoritarian powers. So my question to our panelists, and I'll start with Dr. Del Rio, what criteria do you think should be met in order to end the public health emergency?
Well, thank you for your question, Representative. It's a really important question because the reality is we need to have an off-ramp and we need to know when things will end. I would say that there's certain things that will need to change. The public health emergency gives opportunity for also the government to, for example, collect information, collect data. And that data is critically important for the kind of decisions that we need, right? To know what's happening in the community as far as hospitalizations, as far as number of cases, as far as availability of medications. And if that data is not collected, then CDC and other organizations are going to have trouble getting that information to us. So I think we need to have some modifications in the public health emergency authorization and allow those things to continue to happen when there's still a pandemic happening. And if you remove the public health emergency with the other components. So I think you're going to have to disentangle two things in order for this to work effectively. I think we have talked about some of the things that CDC looked at, number of hospitalizations, to me, one of the things that we haven't talked about is, and to me is something that I think CDC needs to investigate because I don't understand it, is why we continue to have over 1,000 deaths per day in our country as a consequence of the pandemic. I have not seen deaths come down as much as cases, and everybody says, oh, it's going to happen, it's going to happen. It hasn't happened. I would like to see deaths come down to less than 100 deaths per day. And I think if we're down to less than 100 deaths per day, I think we'll be in a level that is very similar to the flu, which is about 36,000 to 40,000 deaths per year. But at this point in time, with more than 1,000 deaths per day, I'm very concerned about that. And I don't know the reason for that. And I think that needs to be looked at in order for us to use that as one of the metrics. I also want to see, I worry about, again, this is not the public health emergency, but this is recognizing that there's an ongoing pandemic. And I would urge Congress to really push to help and to lead in getting vaccination to the world. I mean, Omicron surge in South Africa, Delta surge in India. If we don't vaccinate the world, we are not going to get over this pandemic. And we are just making a mistake, but just focusing on what's happening in my community and not realizing that the disease is still killing 10,000 people daily globally. And therefore, we have to come together. And the US has had a leadership role in global health that we need to really make it seriously. And this is not about giving charity vaccines. So here's some vaccines left over. This is really about a true vaccination campaign like we did with smallpox, a true campaign like we've done with HIV to really tackle the global problem. And that, to me, is a critical component of what needs to happen. So ending the public health emergency, in my mind, is something that, yes, needs to happen, but we need to recognize that the public health emergency is still there. The pandemic is still there, and it's not going to end just because we end the public health emergency.
And thank you for your comments about the vaccinations. And it's why we wanted to have this discussion on boostering people that are at very low risk and may have risk from the vaccination, because we know that it's a worldwide pandemic and we need to disseminate vaccinations elsewhere. So I'm fully vaccinated and boosted, and I gave vaccines in all 24 of my counties, and it used some of the conversations we've had in order to persuade different individuals to be vaccinated when there was resistance. I'm going to yield back my time. I know that everyone's time is valuable, and I thank the panelists again for being with us.
Thank you, Dr. Miller-Meeks. The chair now recognizes Mr. Raskin for his question.
Mr. Chairman, thanks so much, and thanks for putting together this important hearing. I'm glad that we are at the lowest rate of hospitalizations and death from COVID that we've seen since July of last year. And under President Biden's leadership, we are seeing aggressive public health measures working, and we have turned the tide against the disease. One can only regard with some amazement the suggestion by the prior speaker that it's Democrats who somehow have changed our tune. We have wanted to follow science and public health from the very beginning of this crisis. Unfortunately, our colleagues followed Donald Trump in constantly minimizing, miscasting, and trying to diminish the meaning of COVID-19. And there were times when he engaged in pure magical thinking and said it was just going to disappear by Easter. He hawked quack medical cures like hydroxychloroquine and injecting yourself with bleach. And they did everything in their power to undermine the social cohesion that's necessary for successful promotion of a public health program. But America is back on track now, and we are wrestling the disease to the ground with science and with public health working together. And we've gotten beyond all of the conspiracy theory, denialism, and ideological nonsense that we were treated with for 2 years as they brought us to the verge of becoming a failed state, which the political scientists tell us is a state that's unable to deliver the basic goods of existence to the people. Dr. Wachter, I understand that Pfizer has requested an emergency use authorization from the FDA for a second booster shot for 65-year-olds and above. Do you believe a fourth shot is likely to be needed for older adults? And looking ahead, is it possible that the whole population will need more regular shots, kind of like getting an annual flu shot or flu vaccine?
Thank you, Representative Raskin. Yes, I think that's likely. The evidence is reasonably clear. The evidence is that the effect of your first booster begins waning after 3 or 4 months, and by 6 or 7 months out, as a lot of us are, it has waned significantly. You still have pretty good protection against getting very sick and going to the hospital and dying, but less than you did, and you've lost considerable protection against an infection. You might ask, why do we see so little infection around? In part because we're just in that part of the curve of a surge. It goes up and it comes down, but the European data should worry us. So Europe looks the same as the US did, and most of the European countries are now heading north on their case curve. So I think that's going to happen here. People will be more exposed to the virus, and their level of protection has waned from their first booster. As always, we have to look to the evidence to see what it shows. And the evidence is somewhat mixed. There's no question that the next booster, another booster, will raise your antibody levels. There's reasonably good evidence out of Israel, and I think it's going to be important to look at what Pfizer has and is showing to the FDA, that another booster will restore protection considerably. And I think the time is going to be now or soon, because again, we've been somewhat protected by the low level of virus in our community. If that level of virus goes up, then the threat to all of us will go up as well. And so I think it's quite likely that we're going to see boosters in the near future for people over 65. Whether it ultimately is recommended for everyone, I don't think there's any good reason to think it won't be. You start with the people at highest risk, and then over time, see whether the risk is increasing for other groups sufficiently that the benefits of a booster outweigh the downsides. But I think over time, that's
so just to pick up on your point, if we're headed for a period of kind of ebbs and flows, and we know that the disease is mutating, it's unpredictable, it's a volatile situation, Dr. Wen, what practical advice would you offer to my constituents in Maryland who are wondering what they can best do now to be prepared for the next wave, not in a spirit of alarmism, but just in the spirit of solid, healthy, precautionary measures.
Thank you for that question, Representative Raskin. And I would frame this in two ways. One is that there is a difference in the recommendations that I would give to individuals versus to government and to leaders. So individuals should actually try to use this period of relative calm and resume their normal activities if they're able to. Now, there are some individuals who are severely immunocompromised. There are some who have chronic medical conditions and who are elderly, who are still at high risk for severe illness despite being vaccinated and boosted. They should take additional precautions. And actually, it's this group that I am so worried about, because while everybody else is going about their normal lives, we can't forget about this very vulnerable group. I think it's a travesty that the Biden administration doesn't have the funding to purchase additional antiviral pills, that we only have enough Evusheld, which is the preventive antibody, for about 850,000 individuals when there are 7 million immunocompromised across the country. So we have to do a lot more for those individuals. They still need to take additional precautions. But I would actually urge everybody else who is able to resume the things that they've missed, to see their loved ones, to go unmasked if they so wish in schools for kids, because it's a matter of time, I believe, before we may see another surge, either a surge of new cases such that we may need to have our masks come on again, or a new variant arises that may be more worrisome, may even escape the immune protection of our existing protection or of our existing vaccines. And so I think the individuals can use this relative lull for the most part. But I also think that at the same time, it's so critical for our government, for our leaders to learn the lessons that we had before. We cannot wait until there is another surge before we fund preparedness and prevention. That's the whole point of prevention, is that we can't wait and have all of our testing infrastructure break down again and go without the funding needed to purchase boosters. And I really hope that Congress will do everything in your power to provide the necessary funding so that we don't have to see unnecessary loss of life and huge economic and devastating losses too.
Thank you, Dr. Wen, for your great work, and I yield back to you, Mr. Chairman.
Thank you, Mr. Raskin. The chair now recognizes Mr. Christian Amalfi.
Hi, everybody. Thank you so much for having this. I just have one question for Dr. Wen. Dr. Wen, is there a variant on the horizon right now that we are concerned about? I'm extremely unhappy that we were not able to get the global vaccination piece or the COVID package done, something that I've been pushing very hard in Congress. And I'm very concerned that now we are inviting the next variant to come and wreak havoc on our economy. And I'll take your answer offline here.
Thank you. There is a variant that is contributing to a surge in some European countries, and that's BA2, also called the stealth Omicron variant. That variant already constitutes about 8%, I believe the last CDC numbers show, of new cases here in the US. I don't know that this is the variant that I'd be concerned about going forward. What I'm concerned about is the unknowns. It's the variant that we do not yet know, or that may not even have arisen yet. That's what I'm the most concerned about. And I think, to the great points that my colleagues raised earlier, and I'll point to something that Dr. Del Rio said, and that others have said, I mean, we are very concerned about our hospitals being overwhelmed again. We could very well get to that point. And the thing is, as we saw with Omicron, the surge occurs so quickly. It could happen in a matter of weeks. And by the time we know about a new variant, it's too late to prepare for it. And so I think anyone saying that we should end a state of emergency, if that emergency involves funding for preparedness, I just don't think that that's the right approach when we're actually looking at, just let's look around the world. In fact, in some ways, I feel like we're back to 2020 when we're seeing lockdowns in China. We have a refugee crisis that is now, that may cause further outbreaks. We now have cases spiking up in Europe. How is this a time that we are letting up on our preparedness efforts?
Well, thank you very much. And thanks to all of our all the testimony here today. Now, I think we do have time. I know the votes are being called, but we'll try to manage that and go to a second round of questions. In view of that, I have a question I would like to ask Ms. Wynn. What do you think? You know, we've heard the predictions from the Biden administration as to what we can expect if we don't get these additional funds for additional boosters, masks, and everything else that may go along, even treatments that are now being predicted. What would you say to a member of Congress who questioned the need for these additional funds? And there are some who do.
Right. I mean, I understand that so much funding has already gone to pandemic relief. But let's look at the amount that the Biden administration is requesting. It's actually a small fraction of the total that was given, because that, in fact, is the whole point of prevention, that you invest a little bit now that can save much more down the line. And so in terms of what's at risk here, the White House is saying that it can't purchase additional oral antiviral pills, including Paxlovid that we were talking about, this pill that reduces the rate of hospitalization and death by about 90%. Monoclonal antibodies are another effective COVID-19 statement or a treatment, but the administration is saying that there's no more funding for additional monoclonals, and they're going to have to ration the limited supply and cut state allocations by more than 30%, beginning, I believe, next month. This very promising antiviral, or rather, this very promising antibody treatment, Evusheld, that is going to be given for immunocompromised individuals, we don't have nearly enough. And the Biden administration was planning to move forward with another allocation by the end of this month, but now can't do that. And it also means that the Biden administration has also said that they're going to have to close more than 11,000 community testing sites, and that they're not going to be able to sustain the level of testing that's needed. And we already saw what just happened in Omicron, where even people with symptoms or exposure were unable to get testing. It just seems to me that we haven't learned the lessons. I mean, haven't we learned anything from the last 2 years, which is you can't wait for a crisis to occur. By the time you have a new worrying variant, that window for prevention is going to be closed. And by the way, we were just speaking about boosters, and Dr. Wachter gave such a great answer about do we need a fourth booster, which is maybe, right? We know that immunocompromised individuals already need that fourth booster. Does everybody need that fourth booster? Maybe. Or what if we have a new variant that arises and we need a new variant specific booster? Maybe. But the administration is saying they can't even buy all doses of fourth boosters, enough to boost all Americans come this fall. I mean, I just, to me, and I think to all of us in public health, it's really mind-blowing that we can't invest a little bit now in order to prevent something really devastating later, especially because we just lived through 2 years of profound loss and the nearly 1 million Americans who have lost their lives too.
May I add something? Excuse me.
Please do.
Thank you. Just to add, another thing members might do is talk to their constituents. Sometimes I worry that when we have conversations about federal funds, we think about the money staying up here someplace. And so much of these monies are really designed to go to communities, to go to schools, to go to workers, to go to employers, so that they can better protect their workforce than they have been able to do in the past. And so it's not just a federal or state government wanting to see more monies flow. It's actually, I'll say, the constituents, the end users, those who are still trying to recover and continue to prepare for what comes next. And for any particular member, the people that they serve know best what they still need and where they are struggling. And that's also important because there's no one size fits all within any jurisdiction.
Well, thank you. Dr. Wachter? Would you have
yes, thank you. Yes, thank you, Chairman. Not much to add. I guess the one thing I would say is there's a very important equity argument here, which is if the federal government stops paying for example, Paxlovid, people who can afford it will get it, and people who can't won't. And so you will see deaths that are substantially higher among poor people and in minoritized communities. And so that's a really important thing to pay attention to. And I add one more thing, which we haven't really raised very much, which is the surveillance capabilities of our system. You know, the idea that we will look to hospitalizations and see whether hospitals are getting full as our measure of whether to take this more seriously, focus more attention on the state of the pandemic, at some level is understandable. At another level, doesn't make sense, because when hospitals are starting to get full, it means the thing that you tried to prevent happened 2 weeks ago. And so we really need a double-pronged strategy here to not only be looking hard at hospitals and ICU capacity, but also to support the surveillance systems that tell us, the early warning system, that the virus is no longer the way we think it is now at low levels and we're pretty good and things are pretty safe, that it's actually turning around via the wastewater or via random surveillance of people in various communities, or other ways that we have to see what the state of the virus is, because much of this hinges on how much virus there is in the community. And looking at the hospital as your way of telling that there's more virus in the community, it's like looking at a star. You're seeing something that happened a pretty long time ago, unfortunately.
Dr. Del Rio, would you?
Chairman, again, I totally agree with my colleagues. I would just again want to emphasize the issue of health equity, as somebody mentioned, and I think was Representative Waters. The Biden administration put health equity at the center of the response to the pandemic. To me, not having the funds to buy the drugs for those that don't have insurance. 30 million Americans are uninsured. Are we not going to take care of those individuals during this pandemic? They cannot have testing. They cannot have drugs needed for treatment of COVID. I just think that if our focus is health equity, many of these monies are necessary in order to continue fighting the pandemic, because the reality is a pandemic that has disproportionately impacted communities of color, the poor and the underserved, need more than ever the support of the federal government in order to continue confronting the pandemic. I personally, yesterday saw a patient of mine, a woman with HIV that I have seen in clinical trial for a long time. And this woman, who is a Hispanic woman, told me how her brother, her father, her mother, her uncle, and her nephew all have died as a consequence of this pandemic. I mean, it was devastating to me to hear, yet she is the one who had HIV, and she is alive and well. And the reason she's alive and well is because Ryan White allows her to have access to therapy. She's suppressed, her viral load is suppressed. She got vaccinated in our clinic. She's got boosted in our clinic. So even though she got COVID at some point in time, she did fine. And she is, ironically, the one with the bad disease, HIV, is still alive. Other members of their family who did not have access to health insurance, who did not have coverage, are all dead as a consequence of this pandemic.
Mr. Ranking Member, do you have a question? Ms. Waters, do you have a question? Well, it looks like I may be the last.
I think Representative Waters is asking a question, which is muted.
Ms. Waters, I think you may be muted.
We're unmuted now.
Okay.
Mr. Clyburn, I was just saying that there's a vote on the floor, and so only about 5 minutes left on it. And so I thought I would forego my question at this point in time, if you were about to close down the committee.
I was about to close if the ranking member is still there, offering an opportunity to make a closing statement before I close.
Ranking member does not need a closing statement.
I think he's left already anyway. Well, let me thank all the participants for their participation here today. This has been very, very helpful. I do believe that your positions on further funding are very clear. I'm very hopeful that we can get to the point that the Congress will come with these monies. It's very clear to me that 1 ounce, 2 ounce, 3 ounces. Even if there were 3 ounces, if I remember correctly, my science class, that will leave us with 13 more ounces before we get to a pound. So we must do what we can to prevent another significant outbreak. And if there is, we must have the resources, as you said, all of you have said, to have a cure in place, especially for those who find themselves without healthcare coverage. So I want to thank all of you for being here today, and I hope that we'll be able to convince Congress to come forward with the resources that the Biden administration has been asking for, because we as a country must continue to protect and treat all of those who are in need. So once again, thank you, Dr. Mullen, Dr. Del Rio, Dr. Wachter, and Dr. Nguyen for taking the time to participate with us today. And I hope that we will continue to be safe and not be in need of these resources, but I hope we'll be prepared. And with that, this roundtable is adjourned.
Thank you very much.
Thank you, sir.